All right, good morning, everyone, and welcome to June's regulatory roundup. I'm glad you're able to attend. Before I forget, though, on our calendar, we have a July regulatory roundup. But since I've been here at the Home Care Alliance, we've always canceled our July meetings because of vacations and all of that. So we will be taking that off the calendar. We won't be doing a regulatory roundup in July. If something crops up or something's important or it might be the proposed rule, then we'd probably do a separate meeting for everyone. But I just wanted to tell folks so they can take that off the calendar, and I'll have Cynthia take it off on our website. Okay. So I wanted to talk about, as we always do, DPH surveys or accrediting bodies, Joint Commission, CHAP, ACHC. Has anyone on this call had a recent survey that they can tell us about? No? Okay. So I've heard from two agencies actually, and I just looked, they're not on the call. They were surveyed, and one was actually they both were from DPH on time, and one agency on the smaller side, they were done in a day or in a little part of the next day. And again, it's nothing really unusual, except one agency told me that this was the larger agency. They spent a great deal of time on their emergency preparedness plan. They like went over it with a fine tooth comb, like looked at it for a couple of hours. So I just wanted folks to be aware of that. Just make sure that you do your annual training, that you've done internal drills or whatever you need to do. I know quite a few of our members went to our tabletop exercise that we had. And Cynthia actually today sent all of the information for those folks that they need for their requirements for that. So just have everyone, if you might want to look over your emergency preparedness plan, because as my recall, they haven't been spending quite as much time on it as they originally did. But after this agency told me they spent a lot of time on it. And then again, they really are looking at those. Are you following the plan of care? Meaning, but especially the visits. Are you doing the visits that you say you're doing? And if not, is it documented why? So those seems to be the focus on that. TPE audits, I hadn't heard from many people. I think it was actually in the last call, and I said, oh, I haven't heard from anybody. And then everyone started to chime in that National Government Service is auditing. They're looking at medical necessity, homebound, and one agency told me they're in their second round, and actually they're not doing very well in that second round. Another two agencies told me that they passed the first round. So if indeed you're going through it, I would suggest that you spend a lot of time if you're in the first round, maybe put a cover letter or a cover sheet and say, you know, face-to-face is on this page. This is on this page. You don't want to go into a second round. And for those people, I'm actually chatting with them, trying to help them. They definitely don't want to go into a third round. And it costs a lot of money, and it costs money to appeal. So has anyone on this call had any TPE audits lately? Targeted Probe and Educate?
We're going into our second round.
Oh, you are? Okay. Is it the same things, homebound, medical necessity?
Homebound, medical necessity, and we also lost one because nursing continued on after therapy had discharged.
Oh,
And on
okay.
the therapy discipline discharge, they said patient is able to walk unassisted, um,
Oh.
without unassisted with no device. Oh no, she did have a device, inside and outside of the home on even and uneven surfaces.
Oh, boy.
Yeah, that they pretty much shut down. In another month, we had a wound care, wound dressing on this patient, and we lost it all.
Oh, boy.
Yeah,
Yeah, that really hurts. It's difficult. I'm a therapist myself. When those things happen, you just, you have to tell your colleagues, you can't keep this patient on anymore.
therapy DCs. I'm sorry about the wound care, but we can't keep them on.
Yeah, it's a shame, I know. Yeah, that really hurts. So that's probably, if that was a big money, um, that might have been a lot of money. That might have I hope that doesn't make you go into the second round. Or is that the case?
We're in the second round. And I guess they're going to start picking patients in the middle of June for us.
Okay,
They
okay.
give you so many months between the first round and the second round, so you can correct the problems on the first round.
Yeah, yeah. Well, good luck. If you need anything, don't hesitate to email me.
I had another sticking point.
Yeah.
So on the plan of care where it says, what is it? Eligibility for home care.
Mm-hmm.
It says intermittent, was it nursing, PT, or speech?
Yeah.
And I didn't put that on the initial one because at least this is the same statement I've used for years. Okay. Because intermittent speech, OT services do not establish medical necessity for when you're starter care for a starter
Yeah.
care service. They can't stand alone.
So you didn't have OT in there? Is
I
that
didn't
what?
have OT in it. I had an OT in all the research because it can continue
Oh,
on.
oh. I'm assuming you're going to appeal that though.
I did appeal it. I got denied.
Oh, I'd go again.
Or again, okay.
Yeah, go again because that appeal that you did is still from NGS. Your next round is not through NGS.
Okay.
Yeah, and what I would do if I were you, I would go to the Medicare claims benefit manual. Yeah, not processing, benefit manual. And in there it says the disciplines that meet eligibility.
Okay.
And I would quote that and I would say that this is a start of care and just like you explained it to me, actually write that down when you do your next go through your next appeal.
I wrote in the first time they didn't like it, but the second one goes to somebody else. Okay.
Yeah, yeah, and make sure you actually quote the actual citation in the manual.
Okay.
I
Well, I
think.
know they're not going to take my word for it.
Yeah.
No, I got to cite a source.
Yeah. Yes, you do.
Although, yeah, because otherwise, and I said, but we don't have home health aid, and you paid for the home health aid on there. And they go, well, let me see about that. I mean, I don't think the people who are doing the reviews really know the regulations.
Yeah, it could be. They could have new help there that I don't know. I'll keep a track on it though. If others are having problems or they think, because I always can call NGS and make a comment to them that, people are having the same issues or if they're not understanding the regulations or whatnot. So keep me posted if.
Yeah, because I still think, because this is a statement I took from, actually we switched EMRs. I took this statement, I copied and pasted it into the new EMR. So basically, I have OT on the research ones, but not on the slots. But yeah, this has never been an issue before because if you had OT in there, intermittent services, that mean OT was a standalone discipline.
Yeah, you have a point. I try to appeal it again.
Okay, I'll try a third time, second time. But thank you. I didn't realize it went to somebody else.
It does.
Okay, good, thank you.
Yep. Anyone on the call have any other type of audits like a CERT or RAC, anything like that? Any other audits? I haven't heard of any, but I was just curious. Hopefully not. We have enough work to do. Okay.
We've been on an agency for goodness, 6 years now, and we've gotten like one RAC audit.
Oh, that's good. Only one. Okay. Mass Health is doing audits and they seem to be doing 1 to 2 a month. I know I mentioned this multiple times, but they will call you the day before and give you so many patient charts so you can have them ready for them. And then when they come in, they'll ask you for some more charts. They seem to be making 3 home visits. I haven't heard of anyone yet who's had results, even though they've been like months ago. But just across my desk, was it yesterday? No, it was the day before, on Monday. Mass Health sent out, they're doing an audit for the continuous skilled nursing agency. So I don't know how many of you do that, but I used to call it block nursing. There has to be a minimum of 2 hours for a nurse to be in there. There's usually very complex pediatric cases. And so some agencies have both regular home health and as well as the continuous skilled nursing. So there is a request for agencies to send in their blank admission packet, as well as any consents, any paperwork that you give to that patient, really the family, that first visit they want. And when I first read, and I had multiple emails come to me, it almost appeared that they wanted the initial paperwork for all of your patients, from last year. And I'm thinking that can't be, they're only giving us 2 weeks. So I called, and it's just a blank. If you don't submit, you will get a sanction if you're this type of agency. So I'm trying to look who's on this call. I don't think there's many people, if any, who might have that type of service. But I asked them what exactly they were looking for, and they're telling me that they don't have anything specific. They don't know what they don't know, is what they told me. So my concern to them was, well, I want to advise an agency. Should they be giving you the teaching document? Should they be giving you, whatever? And because I don't want anyone, if they left something out and they have it, but they just didn't send it to you, I don't want anyone to get sanctioned because of that. And they assured me, no, that wasn't it. They just want to see the paperwork that each agency has to give these patients. And the sanction would only come about if you don't respond. If you don't respond to the request. Anybody, and you're going to submit to Mass Health through this site. Does anybody have any questions about any of that? No? Okay. Mass Health, as we all know, has the electronic visit verification. I am hearing for agencies that it's not going smoothly at all. And, if anyone wants to chime in and let us know what their issues are, or if you have a ticket open with SanData and they're not responding to you after a week or two, and you try again, then you can let me know the ticket number, the patient. And I've been giving those to Mass Health, so they're aware that agencies are trying, but they're not getting their answers from SanData. So over the past 2 months, or past month, I should say, last month, they did multiple Mass Health or SanData did trainings, but I listened to some of those trainings, and it truly was for agencies who aren't using their own system, who are using the SanData system. So, so it doesn't make sense for anyone who's using their own, and they call that alt or alternate EVV. So this month they are doing an hour training for everyone who's using their own software. And these are the links. Cynthia's going to send this PowerPoint out to everyone after this call. The one on June 11th, the 12th, and the 17th are all the same one. So you can just choose one. And I'm assuming they're going to record them as well, but you only have to sign up for one. So I just wanted to pass that information on to you. That came across my desk yesterday. Just so you know, so the PEPA reports and the CBRs, the comparative billing reports, I know a lot of you use them for compliance. to compare yourself against other agencies in the state and then across the country. And CMS does use these reports. However, they have been on hold for over a year now, and they were supposed to be released earlier this year. And last month, I think I've told you this already, but last month I did get information. CMS just said it's coming the summer of 2025. Well, summer's approaching. I went on the website again today. There's nothing new there, but I just wanted folks to know that it is coming, because I know a lot, as I said, a lot of you use those reports. So for Maverick is the Massachusetts Registry for death pronouncement. And it launched on June 2nd. And all over the weekend, I kept receiving, "Are you ready? Are you ready?" So I sent this out actually to our palliative care and to our hospice groups, but and there was a lot more information, but I just put a few bullets here for you. Frequently asked questions, so the top 10 questions about going live. There is the Knowledge Center for registration partners, and then there's a help desk if you have questions, but they also, for the first time, gave a phone number, because if you're trying to do this and you can't do it, it has to get done. There is a number to call, so I wanted to pass that on for folks. Here are links as well. So, and it's, I know we passed June 3rd, but from the 3rd to the 6th, from 9 to 10, you could have a call. Every day they're going to have a call. These are office hours. And then there's one again. So today there's one from 1 to 2. And then next week, it's just 1 to 2. So those, if you click on those links, once Cynthia sends this to you, you'll be able to join that call. So the post is, right now, Massachusetts uses the Massachusetts order for life-sustaining treatment. It is going to, we're still using that now, but we're going to a new system that's portable, and it's going to be electronic. Portable meaning from one state to the other. Massachusetts will accept a different state, and before you couldn't cross state lines. So they're working on it. It's been taking a long time. I think they're in their 2nd year. I do listen to the quarterly updates. The new information is they're actually testing this is started, which it hadn't even started. It has started. And there's, for clinician training, there is the virtual launch is expected at the end of the year. They haven't given us any details, but it's coming sooner. It's all of a sudden it started to pick up. And I think the only thing the Home Care Alliance, and the reason why I'm listening to this, is so Home Care Alliance can pass on to you folks educational information. When the MOST came out back in 2013 or 2014, I can't even recall, those papers were in the home and no one knew what they were, what we were supposed to do with them. So they haven't left out home health. They know that we'll need some education, not that we're going to be doing these, but how it works. Just because you're in the home with the patient's going to be asking you. And if you are interested, there is a Mass Pulse quarterly newsletter. You can, and it's also, they do a quarterly webinar. You can sign up there. Priscilla Ross is the manager of this whole project. And I know she's not going to leave home health out, because she used to be an executive director of a home health agency. So that's good for us. So I just passing that information on. For folks who have hospice, or for any education people on this call, CMS just released this 9-part video, getting started with hospice quality reporting program and public reporting. And I took a look at it. I haven't actually listened to it, but it's estimated it's going to be 60 to 90 minutes to complete it. It's covering the quality reporting,
separately.
public reporting, HOPE, CAPS, data submission, whatnot. So might
Yeah, we're just doing that for organization. Oh, the reason.
it might be good for your educators or for your hospice department if you want to pass that on. Any questions so far? Moving right along. I wanted to let you know, I hope folks can attend this. I'm actually quite excited. The Home Care Alliance is having our quality and compliance conference. We haven't had one since before COVID. My last one was in 2019. It's coming up. It's June 12th from 9 to 11. I should have had a link to our website here. I'm hoping you can sign up. We're definitely getting nursing CEUs. And Cynthia has processed 3 of the presentations already through the Mass chapter of the APTA, the Mass Physical Therapy Association. And it takes them time to tell us, but I looked over all the information Cynthia had. I think it should go through without a problem, but it is still pending, so I want therapists to know that. And so that's, 4 hours of, well, hopefully we'll get them all. One of our speakers has not given us the information that we need for the physical therapist, but we're hoping to get that. So I hope folks on this call sign up for that. Any questions on that?
Is that home care focused?
Yes.
So like a whole home care? Yeah.
Yeah, it's home care and home health care. I was trying to get, we did get Mass Health's going to do a presentation. Actually, I think they're first. And then there is, well, for general, there's compliance, working on your corporate compliance, you have compliance. And then there's an agency who was very successful. They were a 2 on a star rating and they went up to, I think, a 4 very quickly. And what is the other one on? Oh, audits. But again, it's for home health audits.
Thank you.
Yeah. Who asked me that? What were you looking for, hospice or?
Oh, Colleen, it's Kelly. I was just making sure it wasn't going to tie in some other stuff with like the Hope tool or something if it was generally home care focused.
Oh, yes. We will. I can't see people, so I didn't recognize your voice, Kelly. Yeah, we're going to do, I know Cynthia is lining up things for the Hope. So,
Yep, it's on the calendar already for, I believe it's 3 days in August. So you can already register for it. It's 19, 20, 21 of August, I believe. It's either 1 to 2 or 2 to 3 and 1 hour each day.
and it's
But-
recorded, right, Cynthia?
We are working with Connecticut and Florida on this, so I will have to I believe it is, but I can confirm that.
Okay, great.
They usually are. And but yeah, I just put that up on the site on our calendars, so take a look at it. You can see the details and the pricing and register.
Thanks, Cynthia. So I was going to cancel this meeting to tell you guys the truth because I didn't have much. So that's it for my regulatory update. So if people have questions, I can do questions. But the next few slides, if you decide to stay on or not, it's up to you. But the next few slides is Mass Hospital Association. We've been working with them very closely, trying to improve our transitions from hospital to home. And so we did a member survey back at the end of March. It went into the beginning of April. We have 100 certified home health agencies, 31 responded, and every single person answered every single question, which is unusual. That doesn't seem like that's a great rate of response, but honestly, it is for us. We usually only get about 20%. And Mass Hospital Association asked us to do it because they wanted to hear from home health agencies what are the issues, so then we can work together and try to improve them. And so this went very well. I presented it to Mass Hospital Association. I presented it to, not the case managers yet, but that's next month, in July. And then I presented it to the Continuum of Care Council in Massachusetts and somebody else. I've done it 3 times already. And so now they've asked me to do it again at the Post-Acute Care Summit that is coming up. And we're having a few agencies as panelists to discuss. I'm going to give a very brief overview to them, but I thought you might be interested in what the results. And I'm going to go through this quickly. And if there is member interest, I might do it usually takes me an hour to do this. Well, to explain it to folks who aren't home health agencies, but we might actually just do it for our members, have a call for everyone to be interested. But I thought I'd give you a quick briefing on it. So of course we surveyed, as I said, because of issues, there is this report that Mass Hospital Association puts out every month. It's called Throughput. And it is amazing how many people are in the hospital and they can't get home for one reason or another, or they can't get to a skilled nursing facility, or they can't get to a long-term care. There are thousands of patients who are ready to be discharged, but there's no one to take them. And last month for home health, there were almost 300 patients waiting for service for home health. So that's what this is all about. We're trying to understand what the barriers are. We asked agencies about strategies that they may have. We try to gather the solutions and best practices. And then once we identify this, the Home Care Alliance is going to work on a project with, we're going to start a committee to work on improving our care transitions and working closely with Mass Hospital Association. I'm also working with Mass Senior Care, which is the SNFs, to find out how we can make those transitions smoother, especially, you've taken a patient home or a patient comes home from a SNF and they shouldn't have come home. You know what havoc that causes in the paperwork and that involved with that. So we had a 31 response rate. So what I did was, and I asked some members for help as well, like, what are your frustrations? But there were 10 responses and you had to put them from 1 to 10, 1 being the most problematic for you. So it had to do with referral timing and your intake process, staffing, paperwork gaps. And then other questions, we asked for success, any success they might have had improving with the hospitals, and any suggestions how to improve that. So even though it was 31 agencies, it was a pretty good balance. There were very small agencies, were extremely large agencies. They went from the Cape to the North Shore out to the West. It was a good coverage. So I think we have a good response here. So it's funny that on the right-hand side, you see that bar graphs. That is the order that I placed them in, I guess, randomly. I just listed them all. And then I told everyone from 1 to 10 to put them in the order. And it almost came out, except for the second one, with the agency cannot accommodate the frequency and duration, meaning, if it's a daily visit, maybe they can't take a daily visit, or if it's a BID, that type of thing, as well as they can't get in there within the 24 hours. So as we all expected, 45% of the reason they can't take referrals is because of the staffing shortage. We all know that. 29% is that they cannot do the frequency and they can't ensure that 48-hour admission. And I'm wondering if that might have spiked up a little bit with the new COP regarding acceptance of service policy, although it could have always been a problem, I'm not sure. And then 23% lacked the specialty service, meaning WOCN, IV, those types of things. And then all of the rest, they're all about the same, but 10% was for well, it's a little over 10%. It's like 12% for, you didn't take the referral because of patient safety issues. And what I mean by that is, and I had this in parentheses, the patient was known to you, it might have been an environment, the patient was combative. And then staff safety, and then all the other runs ranked low. They weren't really,
Colleen, it's Kelly. Can I ask a question on this?
yeah.
So I'll just speak for our agency because I do see this. Because I know we've had some issues too in the sense of shortage and stuff. But I find, and I'm putting my hospice hat on, palliative hospice, I apologize. But I find too that some of these patients could be diverted to a different program, hence the hospice or pally, but isn't really approached at the specialty level when they're hospitalized. And my gut is saying because they don't have the time either.
Mhm.
And I'm wondering if there's opportunity in the future to set up some type of education or communication with, discharge managers, case managers, even specialists within the hospitals about having those, I'll call them difficult discussions, because some of these patients, not only do they come on or get denied because of their needs and their accommodations, but they also yo-yo in and out of the hospitals. And I think some agencies too won't take them back because everybody's getting that rehospitalization hit. And it really stems back on a good handful of them that they're not on the right course for what their needs are, be it the doctors don't want to have those difficult discussions, don't have time to have those difficult discussions. We're trying to work here on educating our own staff and trying to get in on some of those patients too, to try and flip them over. But I really think there's opportunity right from the hospitalization stay. Home care isn't home health. I shouldn't say home care because we're all home care. Home health isn't always the best fit, and it's, patient decision and rights. But I also think there's a level of they're not being educated to their disease course all the time.
That's a really good point. Ashley, I'm working with Ashley Kuzminski from your,
Yeah,
yeah, so
because we're working on that internally.
yeah, so she's going to work with me, and that's the committee that I was referring to. But I mentioned this as well to Mass Hospital Association with Adam DiLamino. He's the one who's been working with me, and I mentioned that to him as well. So, and I'm going to call on you probably. We're going to do a call with the case managers. I'll do one first. But Adam is always opened for us to do a mini in-service to these case managers. This might be a perfect topic, or the call is usually an hour. If you didn't think something like that was a full hour's worth of information, maybe 20 minutes just to start the conversation. I could ask him if we could do some sort of a presentation in the beginning, just to start there and then see where those avenues take us from there. We could do something like that if you think that would be helpful.
Yeah, because say it's only like 4 or 5 patients that maybe get into the hospice realm versus the home care, but that opens up 4 or 5 referrals, to those patients that truly qualify. If we could find that happy medium, so to say, and maybe even piloting with a referral source who's on board. We do a lot of informationals and they don't always turn out to be a hospice referral, but a good handful of them do. So maybe being able to collaborate with their local hospices, to be able to, the hospital approach the family, say, hey, we want to have an agency come in and talk to you about palliative and end-of-life care and goal setting. Are you open to that? And take it off the hospital plate, get it on a home care or a hospice, for those hospices who are willing to do that. It could be a win-win for both programs. I know we're open to it, but we're not going to be traveling to Boston.
Right.
Local to us and referral sources, and we're trying to work with them on that locally the best that we can.
Yeah, that's good. That's good comment. Thank you for that. Anybody else before I move on? Okay, thanks, Kelly. This next question, we're asking for the top reasons that patients were not taken under care. So meaning, you all know this, you took the referral, but then for one reason or another, you didn't take them under care, which cost home health agencies a lot of money. And so I know some agencies call it NTUC. So the need for 24-hour care and no caregiver was top. That was 35%. That was the most problematic. Duplicate provider referrals, 28%. I think that was higher before. I've been working with mass hospitalization. What I mean by this, for someone who may not understand, when COVID came, some agencies just closed, right? It might have been small agencies or for one reason or another. And so the hospitals were desperate to get these people out of the hospital. And what they did to accomplish that is they sent it to the referral, home health referral, to 5 agencies. They blasted it out. And so if agency A took it, there was no communication for them to say, I accepted this referral, because then agency B also took it, but they went in the afternoon. And the patient doesn't understand that agency A isn't with agency B. So that agency B who went out in the afternoon wasted that nurse's time. They could have taken another referral. You know, it's just a big cost to home health agency. So I think in the past it was worse, but it's still there. It's still a problem. So somehow, I don't know how, but I'm wondering even if this care transitions committee that I'm hoping the Home Care Alliance can host, we can find out some solutions, but because there's a communication barrier there that has to be fixed. And then 23% was high acuity, they require rehospitalization. And then patient family refused care. Those were the most problematic. And then you can see the other reasons that, you know, not homebound, those things, those were least problematic. We also asked for staffing shortage. So how many agencies were fully staffed? So over 65% of the agencies said that they were not fully staffed. And then we asked, for your staff, are you not accepting referrals because of your staff skills hindering you accepting the referrals? So 61% of the agencies said, no, we're fine with the skills. That's not a reason why we're not taking referrals. But then 39% said it was an issue for them. And so of those 39, the issues were they didn't have WOCN. And a lot of agencies said, we have IV nurses, but not enough. And so that was the other one. And then the third one listed was behavioral health. So those 3 caused agencies not to accept referrals. Any questions? Okay. Then we asked, how are you getting your paperwork? Is getting your paperwork an issue? So we asked agencies, what's your ideal? What would you really like to get? And then what is actual? So more than 2 days. Some agency says we'd love to get them more than 2 days so we can really plan our schedule. 29% said that. The majority, 61%, said 1 to 2 days prior was plenty. And then 10% said, oh, the day of discharge is good enough for them. But what actually happens, agencies tell us, they get the information at the end of the day on the day of discharge. So, you know, quite late the end of the day, you might be scrambling the next day to get the information. It's not the first thing in the morning of the day of discharge, it's at the end of the day. So that's what actually happens. Let me see, I just saw someone in the chat. I'll have to get back to that one. I see someone asking me something in the chat. I'll come back to that. I didn't see it before. I'm sorry. Is that it? That might have been my last slide. Oh, no. Paperwork inaccuracies. So 74% of the agencies reported that incomplete or inaccurate clinical documentation delayed or disrupted the hospital to home transition. And some common issues, which again, cause time and money. You're missing clinical summaries, you have the wrong demographics, you went to the wrong home, they gave you the wrong phone number, the insurance isn't right. You know, and I'm trying to explain to them, no, I don't want to say carelessness, but that makes a big difference to us. And especially if it's an insurance that maybe one particular agency doesn't have a contract with. So those were the issues. And of course, they slow and delay care, as we all know. And then I think this is the last one. So we asked agencies, do you have solutions? Have you been successful? So what are your barriers and your strategies? So people focused on, and this makes total sense, the lack of a shared EMR. Everyone has different EMR, no one's communicating with the other. General communication gaps, not having enough information. You know, for example, as we said, that agency A took the patient and didn't inform the hospital to take those other referrals off the portal. And then another is, and it probably is, Kelly had mentioned, sometimes unclear patient expectations, or the patient doesn't know, or they're expecting, you know, you all been out there, I've been out there. What do you mean? We thought you come out here every single day and you stay with us, and you know, their expectations aren't right. And then so for solutions, some agencies actually have gone directly with the hospitals and they have better discharge coordinations because of that. They're working specifically with the patient engagement. And one agency, they wanted innovative triage models, flexibility for complex cases, and virtual care support was the other. And then agency successes. A few agencies actually commented here. They said they timely they're getting timely referrals because they have hospital liaisons in the hospital, frequent communication with the hospital, they're educating their referral sources, they're volunteering to go out to give the discharge planners some information and education. And then internally, they're saying they've actually improved their internal response time to the hospital. And then the recommendations that they made, they have standardized referral protocols, and timing might help. Pilot a hospital home health collaborations, encourage 48 hours advance referrals, as we saw in another question, and of course, support workforce development and address safety barriers via telehealth. And that's it. Any question? Oh, wait, yes, someone does have a question. I'm sorry. Mass Health is trying to come up with a single evaluation for all LTSS. Would that help with the multiple referral issues? I don't know. Catherine, can you speak to this a little bit more?
So it's sort of beginning stages from what I understand. And Mainstay does group adult foster care, which I know is not quite the same as other folks, but it seems like their idea is that clients who are eligible for various supports wind up having to go through multiple evaluations to determine which supports they're actually best suited for. And this wastes a lot of client and agency time. So their idea is that Mass Health will contract some entity to do one evaluation and then recommend which program would be best, and I suppose refer them to an agency. So there was a lot of push back on that for various reasons, but they're making modifications, but they do seem to be moving ahead. It's possible that this actually doesn't cover home health. It's some different group that includes GAF, but not home health.
Yeah, I don't think it involves home health. I probably would know about it, but it's, it's not a bad idea to try to standardize, have a single referral. Yeah, but I think that's, as you said, it's not related to home health, but it's a good idea. Thank you for bringing that up. And Marissa, Cynthia, after, when the call is over and she edits the recording, because we have to get rid of all that beginning time, she will send out the recording with the PowerPoint, and the PowerPoint has the links to everything that was on there.
Thank you.
Yeah,
Pauline, can I ask a quick question?
sure. Sure.
Going to the Maverick,
Yep.
because, our only deaths since the 2nd have been at wee hours of the night. But I had gone on trying to find a video or a link, and maybe somebody on here has directive that shows the actual form to be filled out. My medical director, who's not overly computer savvy, like I wanted to be able to walk him through it, and I couldn't find anything.
Okay.
So I didn't know if anybody had a link or because I don't want to go in live because we're not doing a patient, you know what I mean?
Yeah.
So he could at least see the form. I keep telling him, don't worry about it. When you get your first one, come in, we'll walk through it together. Because I saw it like over a year ago at a conference when Maverick presented, but then, got put off. And everybody has a live account, but I haven't been able to show him what he's going to see. I don't know if anyone had that or could direct me to that.
We've had the same problem, Kelly, and I've emailed the help desk and never really got anything back that was helpful.
Yeah, I mean, they put out a lot of information that went, I'm sorry, kind of nowhere.
I feel like all the information was great for our nurses, but I've never been able to find anything that could help out our medical director at all.
Yeah,
Everything was very they refer to them in the system as pronouncers. Everything was very pronouncer specific. I never found anything that would have been helpful to the medical director.
yeah, I couldn't like find a video feed of the live entry, like this is what you'll see. So when you get, notified, this is the area you'll go and this is what you're going to put in. Like I have a vision of what it kind of flow looks like, but I can't explain that to him because I can't show him.
Right.
And I'll try to hit one of these live calls, but this kind of falls into the EVV realm in my life. Like they put all this information out, but it was very foreign and wasn't easy to find. You had to really take time to dig in and had to link a link to find a link. And yeah, it was just a huge time. I won't, say it. It was a lot of time.
Well, you know what I'll do, Kelly, I can't remember the women, this is a few months ago, but Maverick had, they hired consultants to help with all of this.
Yeah.
And they had done a little presentation for us, but I have their emails. So I'll email them and tell them, I wrote down what you were saying. I'll ask them, do they have this? And I'll explain to them what the issue is. It's because of the medical directors.
Yeah, because
And
this was geared a lot towards like the hospital type physicians. And I really think, and I brought this up at the meetings I have attended, the oversight of hospice in the home is 24/7. And unfortunately, a lot of our stuff happens after the typical work day. And they're like, well, just, put the body in a fridge. I'm like, we're in a patient's home. Like there's no morgue in the home. Like I can't put them down 3 floors and say, yeah, we'll deal with it in the morning. And they were kind of like, oh, and that was at the Mass Federation conference where they presented, like, I don't think they thought it all the way through. And I said, a lot of our agencies are rural. We're in mountains, as good as the cell towers are, they're not great. And at 2 a.m., no one's sitting looking at an email. So
yeah, I'll bring that up too.
that would be great. Thank you.
Yeah, that's good feedback. Thank you. Anyone else? No?
Oh, I do have a question about the Oasis for all payers taking effect in July. So I mean, we started doing Oasis on everybody back in January, but we haven't had any private pay patients in quite some time. So when we have to do an Oasis for them, well, let me preface this by saying when we had previously a private pay patient, I can't say we handled their chart with the amount of scrutiny that we would have handled the chart, you know, as a typical like Medicare patient. So when a patient is coming on as private pay, you know, do we need to kind of change how we're looking at things and make sure that this is a diagnosis that's you know, almost looking at it like a PDGM appropriate diagnosis? You know, I just wasn't sure how we should be handling these records now that they need an Oasis.
Yeah. I haven't seen anything specifically about that, but, I
You
mean,
know,
you have
like, for example, if they came on with an unsteady gait, that would be the diagnosis in their chart.
yeah,
You know, they're paying privately. There was no Oasis going anywhere, but you know, now you know, I just want to make sure I'm teaching my team how to handle things appropriately. You know, can we use more generic diagnoses for them, or should we, you know, put more effort into that?
yeah. You know what? That's a really good question. We could actually put that into the help desk. But that information supposedly isn't going to go into, they're collecting it, but they're not doing anything with it.
Right.
So I would say I wouldn't change a practice yet.
Okay.
And I can shoot off, sometimes I hate to ask though. I could shoot off a question kind of vaguely. But yeah, even if you're giving free care, you have to do it. You know, that's like, I think
That's crazy.
that's crazy. I think agencies are really having a problem with that one. And I don't blame you.
I
But
could see if they required it with a mini assessment, but that Oasis is like, I'm sorry, there's just way too much data in there. And what is all that data truly needed for?
yeah,
Um,
yeah.
Especially in a private pay and yeah.
Yeah, your
It's-
agency, actually, Ricardo, sent it in to me. So we responded, Home Care Alliance responded to the Office of Management and Budget for deregulation.
Mhm.
And Ricardo wrote up this fabulous, I think it was like 2 pages long, and I didn't change it too much. I changed it just a little bit, and we sent that all in with, I think we had 13 pages of redundancy, duplication. And of course, we haven't heard anything back yet, but at least it was a step in the right direction. They haven't really asked us anything before, except that patients before paperwork, which went nowhere.
But not often. I mean, people are on our private duty and our home care. You know, they could be on for physical therapy skilled, but be on private duty for Medfill and personal care.
Well, see, there's another question, right? And I sent this into CMS and I didn't understand the response. And I asked Mary Carr and she didn't understand the response. So what Kelly's referring to is, so if you're doing an Oasis for someone who you're under Medicare and you're giving them skilled care. However, now you need to do an Oasis for somebody who has
Properly.
private care, right? And the response I got from CMS, because you're not the only one who asked me, and I don't know.
Yeah.
Because is one going to kick out of the system, the other? Or is the system that smart that they see it's a different payer, so it is left alone? The responses I said, I totally didn't understand it from CMS, and I'll be honest, I haven't responded back to them saying I don't understand you, just because I haven't had time yet. But I am going to ask because it's right around the corner.
Well, the other thing, Colleen, and maybe Cynthia might have some info. I think it's Cynthia. There's that other meeting, that other group that meets with I'm gonna call it private pay, nursing, and they're doing, home health aid, and they're not into the certified home, I would think that they're under that regulatory component to some extent, but I can almost guarantee you they know nothing about it.
Yeah, if it's a certified agency doing private care
Then we have-
under their umbrella, then yes, they have to do it. However, some agencies have spun that right out and it's their own like separate business.
Okay.
They don't have to do it.
All right, so if they're not under the certified umbrella of the agency, then they're excluded. Because I'm thinking, how are these people going to do that? Like, it's
Yeah,
easy.
no, I think there's 400 or 500 easy private care agencies here in Massachusetts. They're not regulated.
All right,
Yeah, no, they don't do it.
okay,
Now, there's gonna be licensure in Massachusetts coming up, but I still think that it's not a certified agency. You don't have to do it. Yeah.
Hmm.
Anybody else? Well, that went well. I thought I'd be giving you guys back a half an hour. I guess I didn't. No,
sorry, next time I'll keep my mouth
no,
shut.
no. I'd rather have the conversation. So again, we're not gonna have a July meeting unless something really crops up. And anybody have any questions before we sign off? It's a beautiful day today. No? Okay, well, thank you, everyone. Have a great day.
Thanks, Colleen, you too.
Yeah,
Thank you.
bye-bye.
You too. Bye-bye.
Bye.